Good day to everybody. Welcome to this great Congress. I'm Roberto Ferraresi. My co-moderator is Hiroyoshi Yokoi, connected by Zoom. And we have a great panel with Yoshimitsu Soga, Daniel van der Heuven, Steven Kama, and Koen Deloose. We will have two different cases from Japan, Amagasaki, Dr. Osamu Lida, and Abano Terme, Dr. Marco Manzi. Thank you to the ASAHI company for sponsoring this session. I will start with the presentation on the current status of CLTI. This is my disclosure. CLTI is an unknown epidemic. There are currently more than 500 million of diabetics in the world, and every 20 seconds a limb is amputated due to diabetes. More than 200 million of adults worldwide have peripheral artery disease, a higher prevalence than ischemic heart disease, heart failure, Alzheimer, and cancer. And if we look at the incidence of CLTI in USA and the death rate, you can see that CLTI is exactly in the middle of all the other cancer. But last week I made a research with Google for cancer, peripheral artery disease, claudication, limb ischemia, gangrene, foot ulcer, and diabetic foot. And as you can see, I found more than 5,000 million results for cancer, but very few for all the other voices. Second, CLTI is underestimated. Time is tissue. This concept changed the treatment of acute myocardial infarction. Time is brain. This concept changed the treatment of stroke. Now, these are the months between onset of symptoms and arrival to our centers. 2 months, 9, 4, 3, 1, 3, 5, 6. The dramas of delayed referral. Time must be foot. It's time to apply this winning concept to CLTI. We need a limb salvage centers network. Third, PAD is going distally. The power of peripheral artery disease in leading to CLTI is stronger in small vessels. And last week I made this research on PADMET below the ankle, inframalleolar, pedal, and angioplasty revascularization. And as you can see, I found that there is an increasing evidence, an increasing interest by physicians in going distally. Finally, we are happy that industry is now focusing on CLTI. This is the evolution of percutaneous vascular intervention. The evolution fuel was decreasing invasiveness of surgical procedure and decreasing incidence of restenosis from bypass to balloon angioplasty, bare metal stent, balloon, self-expandable stent, drug-eluting stent, drug-eluting balloons, bioabsorbable drug-eluting stent, atherectomy, shockwave, etc. But we have also an evolution of wires, and the evolution fuel was the increasing complexity of lesion to treat, tortuosity, small arteries, calcium, retrograde, loops, from old wires to primitive wires for CTO and tortuosity. And now, thanks to ASAHI, we have Gladius, Halbert, Gaia, Astato, Regalia, Treasure, O14, O18. So, in conclusion, CLTI is a never-ending challenge. Thank you very much for your attention. Now I think we will move to Japan, I suppose. Osamu? Osamu, can you hear us?
Good morning. Yes.
Good morning. Roberto speaking.
Roberto, good to see you. So I think it's a great honor to be here again in the LINC Live Operator. So I'm Osamu Ida, Hyogo, Japan. So next to me is Dr. Hata and Dr. Toyoshima. We prepared a representative, a very tough case, CLTI case, due to the ET case with severe calcification. So before starting my procedure, I would like to express my appreciation for Dr. Shainat and also LINC organizer, my staff, medical staff, my colleague, and also I have a special thanks to my teacher of the Giancarlo Biamino. Okay, so we would like to start a case presentation. Tak, please.
Oh, thank you. The slide, please. The present case is a 57-year-old male. He has Rutherford 5, non-healing ischemic wound on the right second toe. Risk factors he had are hypertension, diabetes, dyslipidemia, and hemodialysis. His Wi-Fi classification is wound 1, ischemia 3, and foot infection 0. Next slide, please. Endovascular therapy with drug coated in balloon for right SFA stenosis and plain angioplasty for tibial peroneal trunk was performed in April 2021. Today's target atrial pathway is right anterior tibial artery with severe calcification. Next slide, please. We started with ipsilateral antegrade approach from right femoral artery with 5 Francis and planning retrograde approach from dorsal pedis artery if necessary. And I will hand over to Dr. Ida.
Thank you, Tak. So this is a very representative case in Japan. So can we show the angio, please? Angio, please. I'm sorry for upside down angio. So my target is anterior tibial artery. So previous revascularization for posterior tibial artery, but unfortunately wound was delayed. So I decided to perform the ATL revascularization. But I would like to show you this classification status, PAX grade 4, bilateral longitudinal classification at the anterior tibial artery. Also, we have a severe classification at the below the ankle artery. So this is a current situation. So we're gonna start from the ipsilateral common femoral artery. And now I'm just using the Gladius wire from ASAHI, 3-gram wire. This is here. Roberto, any comment, question for this case?
It's a very difficult case, I think. It's a
Yeah,
very difficult case because I have not seen clearly the target. And can we see again the angio of the foot, please, in order to understand what can be the target? Okay, perfect.
So 3 months before, so I performed the revascularization for posterior tibial artery. Yeah. But unfortunately, wire couldn't pass through the plantar artery. So in this timing, we decided to perform the revascularization of anterior tibial artery. But very severe calcification through the anterior tibial artery and the calcified nodule at the distal part of the ATA. So at first, we attempt to revascularize with Antegrade with O14 system. Gladius accompanied with the Corsair. This is the current situation.
What do you use as a support of the wire?
Support wire, Gladius from ASAHI.
And as a support, do you use a catheter? Do you use
Corsair?
A balloon?
Corsair.
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 Okay.
So guys, if you see this amount of calcium, would it be your choice as well, the Gladius, or would you go, for instance, for Halbert immediately, like a CTO wire? Would you try first?
I always try, also like Osamu is demonstrating, with the sliding wire. And only when I'm failing with the sliding wire, then I'm grading up a little bit the tip loads and moving to the CTO drilling wires. Yeah.
Osama, this is Stephen from Singapore.
Stephen.
Yeah, good to see you again.
Good to see you.
And real tough case, I think. Problem of not only the problem of the tibial, but also the outflow. It's not a great outflow. Tell me, when you look at the calcium for this kind of lesions, is that your normal practice to go through lumen rather than subintimal? Or
yes, thank you, Stephen. So initially challenged the interluminal passage, but this kind of patient, I think that interluminal revascularization through the all space is not practical. So if the failed revascularization, I switched to the subintimal revascularization using the 035 baby J-tip wire from Terumo. But
I'm happy to hear that there is someone, another one at least, using no 3.5 wire in subintimal BTK.
Subintimal, traditional.
I think we are the only two in the world, Osamu.
But it's very hard. I think it's very easy to pass the out of vessel. So I think we need to change the strategy using the 014 looped wire technique. Gladius.
So you will use the Gladius PV?
Yes, Gladius ES, extra support, and also
Osamu, this is Tatsuya
Tatsuya.
speaking. So,
yes.
so I think your guide wire is already running into the subintimal or sometimes outside of the vessel. I think the continuous subintimal plastic sometimes expands the subintimal space beyond the CTO segment. So I think it's a risk of the lost the chance of the distal puncture. I recommended the distal puncture in this situation.
Okay. I switched the distal puncture. And also the learning objective in this case is assess the vessel diameter using the IVUS. So before switching to the Manzi's case, so I would like to share the vessel diameter by assessing the IVUS. So from the angiogram, the vessel diameter at the proximal ATA is around 3, but I want to show you this real vessel diameter from the IVUS finding. Can you see the IVUS?
Yes.
This is an AT osseous. As you can see, the real vessel diameter is 4.5. So if I successfully recognize ATA, so I would like to use the 3.54 millimeter tapered balloon for ATA proximal side. This is my current practice. So anyway, so I switch to the retrograde puncture. So before, I want to try to use the 035 traditional way, as mentioned on the Roberto.
On one side, I appreciate a lot what you have shown us with the IVUS, but on the other side, yesterday we were talking about the sizing according the true vessel diameter or the sizing according to the outflow. Because I believe that sizing should also be done according to what is the outflow, especially when you have a poor outflow in patient with small artery disease, medial artery calcification. To have a very big size of the inflow means to have something, what I call a lake effect. You have a big artery with a very slow flow. And on one side, sometimes this low flow can disappear after 2 or 3 days, Andrei Schmidt said yesterday. But on the other side, I remember many cases of subacute thrombosis with amputation. So,
this is...
So Roberto, Roberto,
yeah?
can you hear me? So I would like to puncture the distal dorsal pedis artery.
Yeah.
So I think that it's timing to switch to the Manzi's case. So, okay, so I'll do my best.
Okay. Record, please, this maneuver.
Okay, could you please switch?
Okay. Can we switch to Marco?
Yes?
Marco, can you hear us?
Hi, Roberto. Yes, we can hear you very well. Good morning to everybody in Leipzig. Good morning to you, to Steven, to Pion, to all the panelists. Welcome to Abano. We are here with Dr. Salvatore Esposito from University of Naples and Cesare and all my team that you know very well. And Salvatore can introduce the case for you. And thank you very much for joining us. Please, Salvatore.
Good morning to everybody. Allow me to introduce you the patient we have here today. Slide, please.
Can you see the slide?
Yeah.
Okay.
We have an 82 years old lady with type 2 diabetes, ischemic cardiopathy, nephrovasculopathy, dyslipidemia, a left wet lateral lesion that we are going to treat, a previous contralateral right before the knee amputation, and now presenting with the 20 millimeters of mercury of TCPO2, a Wi-Fi classification 231, and a global limb anatomic staging system stage 3 with the inframedullary descriptor P2. Next slide. You can see the baseline CO2 angiography with a diffuse disease of the distal SFA, with a very stenotic popliteal artery affecting the P1, P2, and P3 tracts, a severe stenosis of the tibioperoneal trunk, in brief occlusion of the peroneal artery and the distal anterior artery, and a flash occlusion of the posterior tibial artery, with a scarce representation of dorsal circulation and plantar circulation. And now I will hand it over to Dr. Manzi.
Okay, we can go, we can show you what we did so far. Possiamo far vedere i registrati, grazie.
Strategy.
Okay, let's go with the... this is our strategies. We deployed Antegrade use-guided 6 French common femoral access. In the reality, I prefer to perform the puncture in the proximal SFA because the patient has a lot of lymph nodes in the groin, and we would like, and we treated the inflow with drug-coated balloon or with DES. You will see what we have chosen. And we would like, and we treated the tibioperoneal trunk with the drug-eluting stents. And for sure, we have to treat peroneal. And we would like to involve you for a discussion for the potential posterior tibial. And then we would like to cross the distal occlusion of anterior and treat the anterior with drug-coated balloon. I can show you the angiography, the today angiography, always a CO2 angiography. We go, okay. So can you see now? Okay, falla andare. Che corra, okay? This is the distal SFA and popliteal tract. Falli girare. Okay. This is the situation in the below the knee arteries. And then I can show you. Comincia con i... Sorry, technical problems. Okay, this is the speed of the advancement of the CO2 gas. Next one. Situation in distal SFA and popliteal. I remember you that the CO2 normally could underestimate the lesion. The flow is not exactly very fast.
Underestimate or overestimate?
no underestimate, because the viscosity of CO2 is very, very low, can pass almost everywhere. And sometimes we consider a very tight stenosis, and with contrast medium, we discover that could be an occlusion.
So it tends to overestimate the stenosis.
Yes.
Okay.
Okay, now, so this is a lady with a previous transmetatarsal, a very huge lesion in the calcaneal. Could you see the picture of the foot?
Yeah. Now,
Yes.
we want to see the angio of the foot. We have not seen the angio of the foot. Okay, this
This is the perfusion angio to the angio of the foot from the groin. And this is the situation. The clinical situation, there is a sufferance in the extreme of the transmetatarsal amputation and a huge lesion in the calcaneal. I did this angio to show you the diaphragm, the calcified plaque with a sort of diaphragm in the tibioperoneal trunk. So we decided to treat the inflow first. You can see here, this is an ASAHI Gladius 1.8. We deployed the wire until the P3. We checked the lesion in the distal SFA. We perform a pre-dilatation with a 4 by 5 by 50 by 40, sorry, balloon, and we definitely treat with an impact Pacific 5 by 60 the lesion in the distal SFA. Then we went down. The next, yes, this is the drug coated. 2 minutes at 7 atmospheres, so nominal atmospheres. The flow was good, no dissection, no signs of spasm. So we went down to change the wire into ASAHI Gladius 1.4. You can see the tip of the bear did a lot of strength to cross the tight stenosis in the popliteal in P2. We placed the wire in the peroneal, and we decided to pre-dilate all the lesions, so from the diaphragmatic plaque to the peroneal with a 3.5 jade balloon 120 in order to improve the flow into the peroneal. If you remember, the peroneal ended with 2 collateral, a posterior and an anterior branch, and this posterior gives some calcaneal branches, but no signs of posterior, and there is no direct communication from the posterior branch to the plantar. We don't have any plantar. And then we decided to scaffold with a create 3.5 by 30 the diaphragmatic plaque. You can see here the placement of the drug-eluting stents, 17 atmospheres. The stent was really good deployed, and the acute result seems to be very nice. And then we decided to go into the anterior, and I'm ready to go in direct with you. We have a Berenstein, the Y connector, the Y. We have the Berenstein catheter for French and a Gladius 1.4 into the anterior. But I would like to ask you, Roberto, Stephen, Kiono, all the panelists, if I take a shot now with 3 cc of contrast medium, if you could suggest me where I can find the posterior. There is no way to understand the anatomy.
What's the opinion of the panel?
Yeah, I think, Marco, this is Stephen. Good morning to you. I think just based on just based on where the wound is, I think you've got a pretty good collateral to supply the heel. So I think I agree. At least the target vessel is the peroneal with collaterals, and this may be enough. Probably be enough to heal the wound on the heel. Sometimes if we go too aggressive to look for the posterior, we might damage the collaterals and make the situation tricky. So I think personally, I would go with your strategy and treat the peroneal as you have treated. Just one question from me, Marco. You've done a balloon angioplasty of a 3.5 on the peroneal. Can you give us an idea on what's your decision between the drug-coated balloon and a drug-eluting stent? Because there were some focal lesions, and would you have considered a spot focal DES with a couple of creates, or primary DCB, or what was your thinking?
No, in this case, I was very worried about the calcified plaque in the tibioperoneal trunk. So I decided to pre-delay 3.5 from the top to the peroneal in order to improve the flow, but to scaffold only the calcified plaque, the diaphragmatic plaque with the drug-eluting stent. So they create 3.5 by 31 was deployed just to avoid any recoiling in the future in that area. But my idea is to show you, because of the sufferance in the transmetatarsal amputation, of course, to recanalize the anterior tibial artery, and whenever possible to give flow through the lateral plantar to the calcaneal area. So if we can cross this occlusion arriving in the foot, we can study if it could be possible all this strategy. So through the bears and through the Y connector, we achieved this angio. We have in place a Gladius 1.4, and so we try to cross this lesion and try to arrive directly into the foot. I would like to have a magnification. Okay, so let me advance the wire. You can see I rotate the wire. I don't want to push the wire. I don't want to achieve a loop. I don't want to knuckle the wire in this moment. And I'm trying to maintain the direction of the wire properly. You can see here there is a resistance in this point, so I would like to avoid to...
Marco, this is Tatsuya speaking from Japan. So which guide wire do you use now?
It's a Gladius 1.4.
Gladius, conventional Gladius? Okay.
Yes. Gladius 1.4.
Thank you.
And in my mind, if I can arrive in the foot, I would like to change into a Gladius FC 1.4 in order to navigate, when possible, towards the lateral plantar. Let me check if it's possible to advance the
Marco?
sign catheter. Okay.
Marco, good morning. This is Daniel.
Hi, Daniel.
Good morning. If you look at the images after your stenting of the peroneal, there seems to be very tiny ostium of the posterior tibial. I don't know if I'm correct, but let's say if it's correct, would you prefer to try Antegrade first?
Well, I can do, if you give me some minutes, we can go there together. I tested, and the impression is that there is a tiny collateral starting from there, and it's not very well promising to be the posterior. I tested this morning, so that's why I in my mind there is this sort of B plan. Posso avere un Navicross 18?
Marco.
Tell me, Robbie.
Now we will let you work alone for some minutes. We have a flash presentation now from Koen Deloose. Antegrade wire escalation for BTK lesions.
Thank you, Roberto. Yeah. These are my disclosures. So my step one approach for BTK treatment is, as we've seen today in the two live cases, is ipsilateral, because this is, of course, more direct. Steerability, pushability, and support is much better than in another setting. Antegrade is the most intuitive and easiest to start with. And then, of course, our first step is to try, as we've seen also in the two live cases, intraluminal passage, because you have a lower technical failure rate. It is not based on blind luck, but on technical expertise. All prepping techniques are possible, so if you want to do a debulking, you are able to do this when you are intraluminal. And in my opinion, it is also an ideal circumferential treatment possible, while we noticed earlier during this Congress that in very difficult and complex subintimal recanalizations that you need to take care with high doses of paclitaxel in order to avoid aneurysmatic degeneration. So the first Antegrade attempt in my service is with sliding wires, and I think this is also nicely confirmed in these two live cases. Here you see a perfect example of an instant reocclusion where we tried with first another wire, tried to go through and through, but with a sliding wire, you see that it was relatively easy to go through and through intraluminally. These sliding wires have very specific characteristics. A hydrophilic coating is essential. They are smooth, they are lubricious. They need to offer sufficient support to pass the lesions. And then, of course, you need to find a perfect balance in between durability of the wire on one side, but also a steerability on the other side. And that's a little bit a contradiction, actually. And the way the engineers solve this problem is in three ways. First of all, there are third-generation wires available where they play a little bit with the nitinol alloy, so a very soft nitinol in the distal part and a more rigid nitinol alloy in the proximal part. They can also play with the core in terms of composition, combination, nitinol to have the durability, but on the other hand, the core more proximal is stainless steel in order to have also the steerability. And then, of course, in my opinion, also a very interesting technology are the fully stainless steel wires, but with dedicated core technology and protected to have also the durability by spring coils. And here you see another example of a hydrophilic, very lubricious wire passing a lesion in the tibiofibular trunk and the peroneal artery without any problem. Here that's another case of Roberto, where you see he was using a sliding wire actually, and this sliding wire was running very smoothly intraluminally all the way down to the foot. And this was completely thanks to the hydrophilic coating, to the lubricious aspects, and also to have sufficient support. You don't see immediately a supporting catheter. The wire itself is supportive, it is durable, and of course also very important steerability. And you see that all the way down through the lumen, this wire is sliding up to the level of the ankle. Of course, a perfect example of a sliding wire, and we've seen it used in the two live cases, the gladius wire. For at least the distal half of the below the knee, we prefer an 014 platform. In the proximal half, you can discuss about an 018 platform. And this gladius 014 is a perfect example. Tip load is just 3 grams, so it's really not a CTO wire. It is a stainless steel wire, so in terms of one-to-one torque and steerability, perfect, but it is also a durable wire, and thanks to the Act 1 technology and then the spring coil, you see that in this way the tip or the proximal part, at least 11 centimeter, is made very durable in order to try to slide all the way down to the foot or to the target vessel. There is a polymeric jacket, what makes it a little bit gel-like and smooth, very lubricious, in order, again, to slide through and through the lesion. A very special sliding wire is the regalia wire. In our service, we use it as a dedicated wire for very delicate retrograde accesses, also for a sliding wire below the ankle work, and to navigate into pedal arch metatarsal arteries in order to avoid any damage to one or another collateral. Of course, this is very nice, this sliding intraluminal technique, but unfortunately it doesn't work all the time. And sometimes you need to use a little bit more power and to drill through and through the lesion. Here you see how we are drilling through a long below the knee occlusion. We have a hydrophilic coating there to make it a little bit slippery, but no polymeric jacket. So gel-like, smooth is not the most important essence of a drilling wire. You need to have perfect support, durability, and of course the tip characteristics are the most important characteristics of these kind of drilling wires. Uncoated, so that you have a perfect tactile feedback, tapered configuration of the tip, and of course you can play with the tip load and the weight of the tip in order to increase your penetrating power. Here again a very nice example, a very tight occlusion, and Roberto tried first with a sliding wire. You see it is parked over there, didn't work, and then upgrading the tip load, switching from a polymeric jacket-based wire towards a drilling wire. You see that this wire was clearly doing the job. And as I've said, you can play with the tip load in order to upgrade step by step the penetration power of the wire. A perfect example is the Halbert wire. We are using quite often this Halbert wire 014 platform. We are speaking about a 12-gram tip load, and I like this because it's a perfect balance in between the 2-3 grams of the sliding wire and then the very aggressive, for instance, Astato wires, where we are talking about 30-40 gram tip load. So a perfect in between. Also with the Act 1 technology, so durable wire. And important here is the round core, so that there is no whip motion. The majority of the wires, they have a flat core, and so every time when you try to steer it, you see that you have this whip motion. Here with the round core, there is a very good torque response. And then if you want to be a little bit more aggressive, you taper the tip and you grade up the tip load even up to 40 gram in the case of the Astato 40. Step 2, if it's not working intraluminal, then you need to dissect subintimal in between the intima and the media layers, but we know that you can have a problem with re-entry. Here you see a case where we dissected actually the subintimal space and went all the way down, playing with the loop of the wire all the way down to the target area. The properties, the characteristics of a dissecting wire: hydrophilic, it needs to be lubricious and smooth, durable because you make a loop and you play with the length of the loop, and it needs to offer you sufficient support. A perfect example of a type of guide wire like this is the Gladius MG 14 extra support. So it has a very strong push force, high lubricity thanks to the polymeric jacket. There is the Act 1 technology, and the most important thing, there is the micro gap for narrow looping. And here you see on this curve in purple color, the ASAHI Gladius MG, where you see that there is a very soft tip, but then all at once, very steep increase of the curve in terms of rigidity or support, what is clearly reflecting this micro gap that is present at the tip of the wire. So the take-home messages of this short presentation: my first approach to below-the-knee disease is ipsilateral antegrade intraluminal. I use sliding or drilling wires depending on the type of lesion. If this approach fails, an antegrade subintimal recanalization is the next step. The dissecting wires are the tools to do an efficient subintimal pass. Thank you for your attention.
Now, can we come back to Amagasaki? Osamu?
Hi.
Hi, Osamu.
We are now, stacking. Extremely hard case because of the severe calcification. So, can you see my angle? No?
Yes.
Yes, so initially the wire was very smoothly advancing to the interluminal space, but this point is very hard. After discussing with Roberto, so I switched to the 035 system. And as Dr. Nakama said, so this is a traditional way.
Okay.
But unfortunately, the wire loop is a little bit big. So I speculate the wire advancing to the out of a vessel. So we switch to the retrograde approach. So we can see the good merychmal, the dorsal pedis artery. And also I use the 014 looped wire technique, but it's very hard due to the severe calcification at the distal part of ATA. Or finally decide to insert the 4 French sheaths at the dorsal pedis artery. And after inserting the sheath, so unluckily, the wire advanced out of the vessel, so I precisely advanced the 014 wire into interluminal space. But it's also difficult, as similar to proximal side. I switched to the looped wire technique, bilateral looped wire technique. Finally, so I succeeded at the middle part of ATA that we conduct a rendezvous like this.
Congratulations, Dr. Ida.
Thank you very much, Dr. Soga. And after that, it's very difficult to make a procedure system. So I switched to the snare technique. After that, I succeeded the wire crossing the fold ATA, but I'm now facing the balloon cannot cross the lesion due to the severe calcification. This is an issue right now. So I challenged to the balloon advancement from the proximal side and the distal side, but around the 40 at the measure, it's very hard calcification here. So I've decided to inner pierce technique from the dorsal pedis artery. Roberto, can you understand?
Wow. You are a fighter. You are a fighter, and there is a war in your cath lab, I believe.
Yes, we have this special weapon.
The only thing that I can say is that I am happy to see that in the other part of the world, the disease is the same.
extremely IFU, out of IFU. But for patient, I decided to perform this strategy.
Osama, I've never seen this challenging technique in live demonstrations.
And now what are you
Dr.
doing?
Ida, Dr. Ida, so you mean the needle inserted
yes.
from the retrogradely, right?
Yes. This technique is use the long 20 gauge needle as the microcatheter.
I got it.
Following the offsetting wire.
Okay, I switched the balloon dilatation from the proximal side. いやいや抜いて。バロン入れて後ろから2ミリ。
If we externalize the wire, we can easily make tension.
Yes.
Therefore, the needle safely delivers following the external guideline. It's a very, very challenging technique.
Roberto, so many Japanese physicians does not this technique routinely. This is a special.
I'm happy with this.
Sorry.
I published this technique 2 years ago in CCI.
He's special. He's special.
Yes.
Come on.
Very hard inflation. Much better.
But in this situation, it's a pull-through situation, so you should pull the guide wire retrogradely.
Retrogradely, okay.
Dr. Ida, I think you delivered the needle from the retrograde side. I think I recommended the balloon delivery from the retrograde. Because,
okay.
Yes. I think it's more smoothly.
無理やめて。Okay. Very tough case.
Yeah, very tough.
Very tough case. So we're gonna perform the balloon dilatation from the retrograde as recommended by Dr. Nakama. So after that, I dilated the whole region with a 3 mm or the 4 mm after assessing the balloon assessment by the IRBS. This is the current status for my case. Robert, Stephen, any question, comment for this case?
Can I just ask, can you give a little bit of the specifications of this needle, the length, the gauge size, what kind of needle is this? It looks more like a sword than a needle, actually.
I think this is a specific for the PTCD for river. The French is a 18 gauge. 18 gauge. So I'm gonna.
And the length?
Okay, we got it. Inflation.
You did it.
Okay, yeah, nice. Did it.
Yes, I got it.
After the delivery of the metal needle from the retrograde side, it sometimes make a very difficult flap. Therefore, it sometimes prevents the device delivery from the antegrade side. I think therefore I recommended balloon delivery from the retrograde side.
Koen,
yes?
This is a needle. I think the length is around the 20 cm. 20 cm.
Fantastic.
Yes. Okay. Dual pathway.
So, Dr. Ida and maybe Dr. Nakama, this is Stephen. Can you comment, years ago when you did the pierce technique, it was very interesting. So can you comment the choice between an inner pierce and outer pierce in this particular situation?
If the guide wire is completely externalized, personally, inner pierce is more safe because we can easily deliver the needle following the guide wires. The pierce is of course very effective, but it's sometimes difficult to pierce. It's easily slip when we puncture the vessels. So of course it's depending on the situation, but in this situation, inner pierce is more safe and effective and promising.
Okay, thanks.
Okay.
But if the type of stenosis is at the proximal tibial segment, delivery of the metal needle is no longer possible because inner pierce technique is dedicated for the pedal artery or distal tibial artery due to the length of the metal needle.
Maybe we can move on with the flash presentation by Tatsuya Nakama while Osamu is continue his fight.
I already recorded.
Okay, can we have the recorded presentation?
Thank you, Chairman, and ladies and gentlemen. The title of my presentation today is a result from Departure Japan study. I think it's a different.
This is
yes,
the wrong presentation.
The concept of characterized DBA is a well-known good option for the
Okay, we go back to Marco.
Yeah. Or the next presentation.
Come back. Okay, come back to Marco now. Marco Manzi in Abano. Marco, how are you?
Hi, Roberto.
Always the same, the spinal plantar loop. You cannot do anything else. Oh my God.
No, I'm trying.
You are becoming old, more than me.
Yeah.
My God. Do something different.
Yes, you're perfectly right, but you know it's difficult to abandon the old way for a new one, unknown. No. So we cross the lesion in the anterior. We perform a dilatation with a pre-dilatation with the 3 millimeter jade balloon, high pressure, almost non-compliant balloon. Possiamo far vedere la registrazione. And then I am checking if it's possible to reach the lateral plantar artery through the collateral. No, l'anteriore. L'angioplastica dell'anteriore che abbiamo fatto. Through the tarsal artery, anatomically, there is a connection with what we call the deep arch. So in most cases, we have an anatomical connection through the tarsal into the medial plantar artery. So I try to check if it's possible to arrive there. So I try to navigate with the Fielder FC wire this very little vessel. This is the acute result. We missed the distal stenosis on the extreme of pedal artery, so we repeated the angioplasty, the next one, with the distal marker of the balloon more distal, and of course we achieved a nice new lumen into the anterior. Then I try to navigate a little bit towards the lateral plantar, but I don't know if it's possible to arrive there. So now I am here and I have in place a 1.5 2 centimeters balloon with the FC wire from ASAHI, the filter. We can check through the balloon if it could be possible to navigate towards the lateral plantar in order to recanalize more directly the calcaneal area. So I take a shot from here. I'm very, very close. What do you think?
It's true. Maybe if you change projection, you can see better the pathway.
Yes, I think that we are very, very close, but the vessel is really, really tiny. So I don't know if the wire can cross this
on one
connection.
side, on one side, you have demonstrated that there is a connection. This means that also if you don't do anything to a vessel which has a diameter probably of less than 1 millimeter, this does not mean that this vessel can function as a collateral, giving blood to that part. So we have a heel with a double vascularization from the posterior branch of peroneal artery and from this branch. So observe, you have blood flow coming competition.
Yes. So Marco, what's so special about the fielder wire?
Yeah, I like this wire because the extremely soft tip can let us navigate in the tortuosity of the foot in the collateral. But of course, if the collateral is smaller than the wire, we have difficulties as well. So. But I would like to add a comment to this wire that the body of the wire, despite the softness of the tip, the body of the wire is stiff enough to let you use balloon cross the lesion. We had this wire in place and we performed the angioplasty with the long balloon, so 123 millimeters with this wire. And okay, the balloon is an excellent balloon. So the jade balloon from Orbus Nike is a rapid exchange, ultra thin, ultra low profile balloon with a fantastic range of sizes, but with a fantastic behavior in the inflation. So it's an almost non-compliant balloon with a very, very, very low compliance. And so the effect on the vessel is really good. So if you want, we can check a perfusion angio at this point just to decide together if I need to insist to arrive to this lateral plantar as I projected, or we can think to stop now. I can show you the perfusion, the 2D perfusion. Puoi mettere la perfusion per favore? The 2D perfusion angio algorithm from Philips. You can see here the previous aspect. The pre-treatment aspect, we have the possibility to put the amplifier in the same position with the same angulation and with the same magnification. We have 31, so let me, okay. And then we can perform the sobreposition of the foot with the previous one. And then we inject 9 cc of contrast medium with 3 ml per second in order to have the same perfusion aspect. Of course, now I have the balloon reducing the vessel, but I can do like this, and then if we need, we can go again in the foot. Don't worry.
Marco, how many milliliters of contrast dye do you use to get this perfusion imaging?
9 ml of contrast medium, pure contrast medium, 3 ml per second.
And do you use vasodilator before?
No, we didn't inject so far, and the pressure of the systemic pressure of the patient now is 149 on 78. Ok, ferma col piede, ferma con la gamba, cara. Mi raccomando, è importante. Posso andare? Ok, let's go. Ferma. Okay, now we are going to compare the two perfusion.
Okay.
And
I think it's sufficient, Marco.
Yes, I think so. It's completely different.
Thank you so much for your great work. Next year, we want to see a capillary puncture, remember?
Hey.
A capillary loop, okay? Thank you, Marco.
Okay, I will do.
Now we will have the correct presentation by Tatsuya, distal puncture and retrograde looping wire technique.
Thank you, Chairman, and ladies and gentlemen. The title of my presentation today is Distal puncture and retrograde looping wire technique. Looped wire technique is very useful technique for CTO crossing, especially in long lesions and with ambiguous route. However, it's sometimes difficult performing with only conventional 14 or 18 guide wires. Because, of course, basic conventional guide wire is not dedicated for such a kind of the looped wire technique. Once guide wire loop became larger, the guide wire wandering into the very deep subintimal space or sometimes go down to the outside of the vessels. Gladius MD series 14 and 18 is looped wire technique dedicated guide wire. It easily makes a narrowing loop due to its unique structure of the guide wire core. If you use this looped wire technique dedicated wires, you can easily make narrowing loop during your procedure. However, of course, looped wire technique often required bidirectional approach. Combination of bidirectional approach and looped wire technique is very mandatory technique. However, of course, it needs additional distal side puncture. Recently, we performed retrograde narrowing technique to simplify our complex endovascular procedure. I'd like to show a case. Patient is 80s male. He was suffering from multiple toe ulcerations. As you can see, control angiography showed opened patent peroneal artery, but unfortunately, both anterotibial and posterior artery are completely occluded. Which tibial artery should be recanalized? Unfortunately, we cannot find the dorsal artery segment. We can see the very distal part of the posterior tibia and common plantar artery. It's still open. I think a recanalization procedure for anterior tibial artery may be impossible because of the lack of the distal landing zone of the guide wire. Therefore, we try to recanalize this very challenging occlusion of the posterior tibial artery. Because we cannot find the entrance of the posterior tibial artery, therefore we performed the retrograde first approach. Distal posterior tibial and common plant artery is very tiny. It seems very difficult to puncture, but we carefully tried this very challenging puncture. In EpiView, we advanced the puncture needle with the indent position of the target arteries, and then we check the ipsilateral oblique position to check the guide wire and needle depth. We have to check the relationship between the needle tip and target arteries. We finally succeeded to with these challenging punctures. We insert radius mg PB 18 and following O18 dedicated microcatheter. After the retrograde guide wire insertion, we advanced the guide wire with the narrowing loop technique carefully. As you can see, our narrowing loop nicely crossed the interluminal space. Therefore, finally, retrograde guide wire completely passed the whole of the CTO segment. We dilate the whole of the lesion with 3.0 millimeter balloon. And we also dilate the medial plant artery with 2.0 millimeter balloon. This is a final angiogram. Occlusion of the posterior tibial artery and nicely recanalized. Lateral narrowing loop technique is a very useful technique, and combination of this technique and radius MGPV 18, it's a dedicated guide wire for lateral narrowing from loop technique, is very nice option for your complex procedure. Thank you.
Thank you, Tatsuya. It was a wonderful case, And again,
thank you.
Again, looking at these cases, I understand how difficult it is to judge properly the outflow in the foot. Because in many cases you don't do anything because on the baseline angio you cannot see anything, but only trying to go distally you can really evaluate what is the outflow. And also, despite this SAD-MAC disease classification, etc., you have in many cases like this a good outflow, sufficient to maintain a blood flow, sufficient for healing, etc. So thank you very much for this case. It was wonderful. Can we come back to Osamu, the battle of Amagasaki?
Battle in Amagasaki.
Hiroyoshi, can you say something, comment something about Osamu's work?
Yeah, very, very challenging and tough case.
Dr. Yokoi, so I am very sorry for off-label use in the live demonstration.
No problem, that's okay.
But an unavoidable situation for the patient. So after successful wire crossing, any balloon cannot cross the lesion. So I decided to perform the inner pierce technique.
Mm-hmm.
After that, I succeeded the balloon dilatation for 480 lesion. This is a inner pierce. Sorry, again, please. Inner pierce. After that, balloon caster. Unfortunately, advanced antegrade pass balloon could not pass antegrade lesion. So Tatsuya mentioned that I used the balloon from the retrograde. Balloon smoothly passed through the region. We finally are using the Gladys wire successfully closed the dorsal pedis artery like this. Wire. So we dilated the full region using the 3 millimeter balloon caster. I think the unavoidable situation because of a severe calcification, we saw the severe dissection on the proximal side, but we can see the antegrade flow, almost the same flow speed compared with the posterior tibial artery. And we also detected a good outflow at the dorsal pedis artery. So I think the tissue loss is minor. So we expect a good time course after revascularization. Thank you very much.
Thank you.
Excellent.
This is the final answer.
Congratulations.
This is a
Extremely
really
tough
case.
case.
The question in the audience.
Okay, please.
Okay, any comment, question for this extremity case?
Yeah. Good morning, Samu. Just one technical question with regards to the wire you use for the inner piece. Do you have any specification with regards to the support or any hydrophilic coating that may prevent the use of this guide wire in this technique?
I think it's up to the condition, but I think the non-coating wire is better. So it's a risk for the reducing the coating after passing using the needle. But in this situation, just a hydrophilic wire close the lesion. So I finally decided to using this needle through the hydrophilic wire. Thank you. But it's up to the condition.
Roberto? I'm Yokoji. I have one question to European doctor. In Japan, that we don't have the atherectomy devices, so only balloon angioplasty. So this special technique exists. So in your European country, you have atherectomy devices. So in this tough case, severe calcified, not balloon pass, you do the atherectomy device or other?
Personally, I have not the atherectomy device due to the cost of atherectomy device in Italy and absence of any reimbursement. In this case, personally, I do what you have done, the piercing technique. I have not this long needle, but I can pierce the lesion with the back tip, for example, of an 18 wires multiple times in order to make the lesion less stiff and to be able to cross. And obviously with the rendezvous approach, with this telepheric approach, we can pull and push the balloon with a higher force. What's the opinion of other people? There is another question from the audience.
Hi, phenomenal case. Thank you very much for sharing your skill set with us. I have a question about, one challenge you've already surmounted, which is to create a communication to the pedal circulation. What is it that you found useful from a post-operative pharmacological management standpoint to ensure that it stays open? How do you do the standard DAPT for these patients? Do you prefer to use Coumadin for these very challenging cases? Thank you very much for your answer.
I think we have no rules.
Yes, Dr. Ida, I think the question is, what is your medical therapy to maintain flow?
I think the DAPT is a standard therapy for the peripheral intervention, but currently, so DOAC, your anticoagulant therapy is one option for reducing the risk of the reocclusion, but in the below the knee case, I think the standard therapy is DAPT. 1 month DAPT, after 1 month of single antiplatelet therapy to prevent the reocclusion as well as to reduce the cardiovascular risk. But as you know, this kind of patient is very high risk for bleeding. So I hesitate to continue the DAPT for lifelong, but it's up to the treatment strategy, BTK and the SFA. That's why I prefer the drug balloon-based therapy, this kind of the complicated patient. Thank you.
Dr. Ida, just one last question. Do you use cilostazol routinely in your patients, and would this be an appropriate case?
Thank you very much. The cilostazol potentially improve the microcirculation thanks to the vasodilatation effect. So if the patient have the suboptimal revascularization for below the knee artery, so I prefer the silostazole administration for this kind of patient. But it's up to the complicated with heart failure or something, coronary artery disease. But in the view of the CLTI treatment, I think the silostazole is the one option for the medical therapy. Well, yes, Stephen, thank you.
Thank you.
Thank you very much. I think we are at the end of this session. Thank you very much, everybody. Thank you, Osamu. Thank you, Yokoi. Thank you, Marco, for these wonderful cases, this wonderful presentation.
Thank you
Bye
very much.
Everybody.
See you in Leipzig next year.